Research progresses, we move on to newer advances. I call upon Dr. Sodhani. He's the R&D project manager at NMODE's GmbH, a startup in the cardiovascular space. Dr. Sodhani has a PhD in hybrid aortic valve from RWTH Aachen University, and he is an engineer by training. His topic is the world's first long-term respiratory assist system. Welcome, Dr. Sodhani.
Thank you. Can you hear me? Am I
Yes,
audible?
we can.
Yeah, great. The world first artificial lung support. I hope to, or we hope as a company to get there. It's a very ambitious goal for us. But what I'm going to talk about is a long-term passive artificial lung support that we are trying to develop. So before I start, I would like to say thank you for the invitation to the organizing committee. And yeah, let's get on with the topic. So moving, we can, yeah, so that's the outline of my talk today. I'll start with a small motivation, starting why do we need artificial lungs, talk a little about the state of the art technology, what we have, what we are using, then the rescue technology that we are developing. I'll show you some results from our animal study, and then I will conclude the talk with a conclusion and an outlook. Moving forward, yeah. So for lung failure patients, in conventional treatment strategies, artificial lung support is initiated, and the other traditional treatment options like mechanical ventilation fail to improve the patient's status. Mechanical ventilation is also often linked to oxygen toxicity and barotrauma. The patient is sedated and bedridden, drastically reducing their quality of life. The evolving new strategy is to provide this artificial lung support, which is initiated at an early stage to allow the lung to rest and recover. Artificial lung can be weaned off in some patients because of improvement in patient condition, whereas prolonged lung support might be required for other patients, for example, patients for bridge to transplant or as a destination therapy. So, what tools do we have for this? Now, if we compare ourselves to other very important field, advanced heart failure, we see that they have now tools available for short term, like ECMO or percutaneous VAD, from mid to long term, which is paracorporeal VADs, or even then long term support with implantable VADs. But when it comes to advanced lung failure patients, we really have only one option, which is the extracorporeal circulations. So, the ECMO devices for short term usage. Some studies have now come up with paracorporeal devices, primarily using the ELA from Novalung as a mid-term device, and long-term or implantable heart devices are still under development. So, looking at ECMO. ECMO is, as of course everybody knows, can be used for bridge for recovery, bridge to lung, or heart lung transplantation. It has its advantages. In the last couple of decades, it has shown a good tolerance, efficacy, and safety in its use. We can now have awake and ambulatory ECMO patients who can then have physical therapy before transplant, which then results in better outcome in post-transplant cases. But it comes with some limitations. One, we all know that ECMO is often linked to shorter duration, resulting in better outcome. Prolonged ECMO could lead to muscular deconditioning, pulmonary overload, increase in left ventricle afterload, blood loss, hemolysis, and even infections. It can result in acquired von Willebrand disease. The oxys that are used in these ECMO circuits are often prone to clotting. That result means we have to change oxygenators often, or we can also have embolic events. Even though more and more devices are now coming to the market, which are smaller, compact, it is still difficult in portability and creating mobility for the patients. And last but not least, we really need a really highly skilled team of patient management. This makes the whole therapy still complex, even though it is becoming popular, but it is still very complex. Now, looking for or focusing on lung failure, one of the uh, prevalent cases are the pulmonary arterial hypertension, which then results in a pressure overloaded right heart that leads to dilation of the right ventricle and eventually the failure of the right ventricle and the preload deprived left ventricle. So ECMO can be used here as a treatment for unloading the right ventricle, but has its drawbacks. A prolonged active right heart support may lead to pulmonary overloading as well as then consecutive lung and right ventricular damage. Paracorporeal lung support for pulmonary hypertension is being reported. A lot of cases have been reported in the last couple of decades, which includes primarily the ELA oxygenator from Novalung, or Novalung, which is from Tsenius. One such study came from the group of or was reported by Camboni. What we see here is this ELA device, and what we see here in black is basically thrombus. The flow is now only going from the bottom part of this device to the patient. So a very low flows domain, but a very big device then leading to a big thrombus formation. Similarly, another study was reported by Stoiber et al., where a patient was on ECMO for 62 or paracorporeal support for 62 days, but did require 4 oxygenator exchanges. And this was also done with the ELA. So we can safely say that in today's day, there are no conventional devices out there that are optimized for the PALA support, that is pulmonary artery to left atrium support. These are generally low flow systems, and then with low flow you have the risk of thrombus growth in these systems. Moving on to the state of the art of technology today, I will start with a brief history. The development of oxygenators started back in the 1950s with parallel plate oxygenators, where the idea was the survival of the patients. It improved, the size of the devices reduced when hollow fibers were developed in 1970s, but the idea still was the goal was still for the survival of the patients. Somewhere in the mid 90s, they started research started on microfluidics, which is still in its R&D stage, and we don't have any devices which use that currently. In the last couple of decades, we have improved, or the therapy has improved from just survival to having mobile and conscious patients with better quality of life. But the idea still remains to provide a more comfortable and physiological device for improved quality of life in patients. So what are the approaches that we have for lung patients? Of course, ECMO, which is the standard right now, and more devices or case studies are coming up in paracorporeal approach, which is again primarily using the ELA device. Implantable hearts are still in R&D and of course need a couple of more decades or even more for research to have some device like that on the market. So how do these oxygenators function, or these artificial lung function? So conventional artificial lung, in this case, a folded ELA system or a rolled highlight system, is based on rolled and folded PMP fiber mats, which filter blood providing oxygen and removing the carbon dioxide. They are rigid and non-compliant as compared to the native lung, which is flexible and responds to pressure changes. They have a high flow resistance and pressure loss, whereas the lung itself has low flow resistance and a low pressure loss. How the flow happens in these systems is really a black box. There is no way of controlling how the flow happens in these systems, whereas in the lungs, it is self-optimizing with respect to the flow. In an ECMO circuit, what then happens is we have unphysiological pressure and velocity peaks, which is then not good for the patients. Moving on, how do these flow work for, let's say, a paracorporeal system? So if you have an oxygenator, there is a blood inlet. What happens is the blood tries to take the shortest path to the outlet, and then there are zones, which are these critical areas where there is no flow, or a dead water zone, basically, where thrombus formation can occur. Once again, I will go back to this example where you have this ELA device. The flow comes in here at the bottom and is out from the other end. And the majority of the oxy over here does not receive a lot of blood flow, resulting in a massive clot formation where only a small amount of the oxy is required, or the membrane is required to oxygenate this patient. So clearly, the aim has to be to develop a passive physiological artificial lung or a right heart assist system. This brings us to our rescue technology. What you have here is the first prototype of our rescue device. You can see how small and compact the device is. This packs zero point 0.6 square meters of PMP fibers and can be used for partial support or for right heart failure patients or lung patients up to 2.5 liters per minute flow. So what are really the challenges and requirements for developing such device? First, often we have to use these devices with a failing right ventricle as a pump. Because it's a right ventricle support system, then it needs a low flow resistance through the fiber bundle. We also should include compliance to reduce the afterload. And as it is connected to the lung, of course, the gas exchanger is required. The first movers for this is the group from Professor Bartlett, who were developing such devices and have shown multiple approaches where they had compliance in the graft, which still has then the high resistance of or pressure drop across the fiber bundles, or using compliant housing, which then results in shunting of flow. So the aim, what we try to achieve in our rescue technology is to incorporate this compliance within the fiber membrane or the membrane that is used for gas exchanging, but the connection is still pulmonary artery to left atrium. Here is a schematic of how we do it. So we have our blood inlet and blood outlet. You have hollow fibers, the PMP fibers all over. And within those PMP fibers, we embed a compliant element. In this case, we are using a silicon tube and wrapped by the PMP fibers around it. This then leads to a compliant element in the oxy. Now, how does it function? In a low pressure point in the circulation, these compliant tubings do not deform, are in its original shape and allow for the blood flow. But when it comes to the high pressure system, these tubings then deform, providing the compliance required and also distributing the flow around uh, and helping the flow for a better washout. What this results in is we take away all these extra pressure and velocity peaks and have a more physiological flow. What does this mean for the blood flow in the system? So we have, instead of these dead zones, what happens is when the blood goes from the inlet to the outlet, these pulsating or the collapsing and, deforming and non-deforming tubes then pushes the blood all over the fiber bundles, which then results in an improved gas exchange efficiency. It reduces the shunt flow and avoids recirculation or the dead water area in the oxygenator. So what do we expect from our rescue technology when it comes to oxygenation or the right heart support? Just a schematic or a CT scan image under what you see is these are the PMP fibers, and this is a silicon tube which is embedded in the PMP fibers. And what you have is when you have blood flow, these PMP fibers can then deform and go back to its original shape, providing that compliance. What we expect is that we have incorporated a flexible movement, which is similar to the lung, which should then dampen the pressure peaks, reduce the RH afterload, reduce the flow resistance and pressure loss, maintain the native right heart pressures, control internal flow to improve the washout, which they should then improve the hemocompatibility, and also include a responsive diaphragm, which then should result in cardiopulmonary stress relief. So now I will move on to show you some results from our in vitro and animal studies. What you see here is the compliance chart. All these experiments were done using the ASTM standard. So what happens is we take the oxygenators and put it in a closed circuit and fill it with fluid, resulting in a certain pressure. And then when you add extra fluid to the system, we see what is the pressure rise. What you see here in black is a steep pressure rise for the pediatric quadrox, where addition of minimal amount of fluid resulted in a high pressure change, whereas in our system, we could easily add up to 30 milliliters of fluid with just a pressure change of 5 millimeter mercury, which is very close then to the native compliance of the blood pathway in the lungs, which is approximately 6 millimeter mercury. Now, looking for at the pressure drop, with what you have here is the pressure loss versus the flow curve, and you can see that even for 2.5 liters of flow, we are still below the 20 millimeter mercury mark, which is approximately the pressure loss or pressure difference that one observes between left atrium and pulmonary artery. Whereas for a quadrox pediatric, for 2.5 liters flow, you have really a high pressure loss. With respect to gas exchanges, oxygen exchange and carbon dioxide exchange, you see that we are relatively in good domain of gas exchange. What is of course worth noting is then our system over here, the rescue system, had only 0.6 square meters of fiber, whereas the quadrox pediatric has approximately 30% or 33% more fiber area. And the Lilliput from ECMO device has fairly similar to what we have in our rescue system. So for the values that we have here, for around 1.5 liters, close to 60 or 58 milliliter oxygen per liter of blood of oxygen exchange, and around 50 milliliters of carbon dioxide exchange per liter of blood. Moving on to the animal trials, we carried out 4 acute animal tests. We used a 14 millimeter graft to the pulmonary artery and a 24 French cannula to left atrium. The tubings that were used were 3/8 inch, and the total tube length was less than 80 centimeters. Of course, now there is no pump. We use banding in the pulmonary artery for creating the cases, and then we measured the pulmonary pressure and flow with or without the rescue device. So this is the animal model. What we start with is the cardiac output. So what you see in black here is the baseline cardiac output of the sheep, which was around 3 liters per minute. We induced a pulmonary hypertension case and then connected the sheep to our rescue system, or connected the circulation to the rescue system. And we see that we immediately, or we recovered our cardiac output of almost close to 3 liters per minute. Moving on to the systemic recovery, what we have is the mean arterial pressure ratio, or ratio of mean arterial pressure versus the pulmonary arterial pressure. The baseline is there, induced pulmonary hypertension, and the moment we connect our rescue system, we have increase in this ratio, resulting in some systemic recovery. We also carried out a comparative measurement of this setup with a quadrox pediatric in this case, where we are looking at the pulmonary artery pressures, which was in the baseline around 25. We induced a moderate pulmonary hypertension, where the pulmonary artery pressures were raised to around 38 to 40. And on connecting that to our rescue device, the baseline pressures were immediately achieved, whereas connecting the quadrox pediatric oxy, which you see here in light blue, we did not see any recovery. Moving on, we also tried a very severe pulmonary hypertension case where the right heart started to fail in the sheep, which you see here in black. Again, connecting that to our rescue system, we were able to achieve the baseline support or baseline pressures, whereas the quadrox oxygenator, or the quadrox pediatric in this case, did not help at all. So all in all, I think this proves, the animal study proved our theory and our concept, how the rescue device could help as a long-term or oxygenator in, let's say, a paracorporeal approach. So to conclude, the rescue device that we are developing is a passive right heart-lung support system, which is connected through pulmonary artery and left atrium. The oxygenator technology in this case has been integrated, or the membrane that is used for oxygenation has been integrated with compliance. Our in vitro results show that our compliance is very close to native compliance, much reduced pressure drop. We have efficient gas exchange. The in vivo results showed that we had a support of up to 30 to 50% of cardiac output, reduction of right heart afterload by approximately 41%, and recovery of the cardiac function. What this would mean is our rescue technology going forward would be easy and comfortable to use. As it's a passive system, there is no energy, no control algorithms required. It would be compact and physiological, so one could wear this device around. And as we have compliance in the system, if needed, an active compliance or a pump could be added to the system to have an adjustable compliance. For us, the next outlook really for the development is the usability analysis of this device. We are working on the cannulation strategy. If it has to be a paracorporeal device, grafting and one cannula will probably not work. So cannulation strategy and cannula development is work in progress. We are, for our design and development, already an ISO certified, ISO 13485 certification has been achieved. And then it would be verification, validation, clinical trials, and market launch for the device. Some of this, what I presented here, was also published by our clinical partners at Leuven. This is the paper that you can find. Thank you for your attention. I would just like to thank our clinical partners and sponsors for the development of this device. And now I'm open to questions. Thank you so much.
Thank you, Dr. Sodhani. Looks like rescue may be the next kid on the block to come to rescue of our damaged lungs. What is the
We certainly hope so.
Did you name it intentionally?
Yes, the team at NMODS over here, we intentionally named it like that.
Okay. Thing is open to the audience for questions. And Dr. KRB would like to ask.
Hello, Dipanshu, that was a lovely talk. The first question I have is, in the R&D space, I think you need better technologies to visualize both the blood flow and the gas exchange. Have you used 4D MR in any of your experimental animals to look at the flow patterns inside the oxygenator, perhaps superimposed on a ventilation scan so that visualize the VQ mismatch in an oxygenator situation in a sheep model?
That's a good point, Dr. Bala. I mean, we only so far carried out 4 acute trials and are planning the clinical trials, so we haven't had the option to use that so far. And that thing is also I think it's not available at the Leuven Animal Trial Facility. So we should definitely do something like that to see how the flow is within the system. But so far, we have not managed to.
The other question, I think I raised it when we had a discussion in the past. This compliance chamber that you speak about, I understand that it helps in absorbing the systolic pressure from the pulmonary artery as a compliance chamber. But have you considered incorporating some kind of, I know the material science is a limitation, to mimic a normal lung and have a expansion and contraction of the fibers when gas is passed through the oxygenator?
Yeah, I mean, that I think is often limited by the fibers itself, them being so like 300 microns or even less in diameter, and expanding those would be trying to develop a new kind of hollow fibers. And that is already, I mean, these fibers are very limited and already pretty expensive. So that is definitely an R&D space one can look in. But at this point in time, the idea for us was to use what is commercially available and try to incorporate the commercially available technologies to try to get it to patients as quickly as possible.
The other thing is, if you want to increase the surface area of the
Yes.
oxygenator, which would lead to greater pressure, lesser pressure drop, and you would mimic the normal lungs vascular resistance. Instead of, I think we have been stuck with the same shape of oxygenator for the last 3 decades. Since you're looking at a wearable oxygenator, have you considered other shapes like a wearable belt or wearable UN jacket, so you can have a very large surface area of the oxygenator so that the pressure drop is very little?
Yes. Again, over here, the limitation really comes from the fibers that are at hand. The PMP fibers are really fragile, and bending them over large surfaces can often result in their breakage, and then plasma leakage can occur. And that's the reason you see traditional shapes, the square or the layered or the wound oxygenators in their shape. It's the limitation that's come from the PMP fibers. I mean, if we are able to have fibers which are bendable and still do not destroy themselves, then yes, we could definitely consider longer or other designs for the oxygenators. I mean, in our case, this is one example that we are showing. We are now also then considering double chamber systems, but in the end, they're all either wound or layered, because that's the best possibility that we have with these PMP fibers. I hope that answers your question.